Good evening, ladies and gentlemen. My name is Colin Lynch, and I'm a member of Sunnybrook's Board of Directors, and I'm very happy to welcome you to tonight's discussion about heart health. February is Heart Month, and although COVID-19 has taken up the majority of our educational interests in the past year, it's important to bring attention to the immense significance of cardiovascular health in our communities. Heart disease remains the second leading cause of death in Canada, and as we continue to navigate the constraints set by the COVID-19 pandemic, Heart Month serves as a timely reminder that heart disease doesn't pause in a pandemic. We are especially fortunate to have a panel that can share their expertise with us about a variety of topics related to heart health tonight. We'll be covering some of the knowns and unknowns of COVID-19 and how it affects the heart diseases like spontaneous coronary artery dissection, or SCAD, and current guidelines around procedures like aortic surgery. As always, we're very pleased to deliver our speaker series to you, albeit in a virtual format now. It's an excellent way to engage with you, our patients, and community members with relevant and timely health information. We sincerely hope that you find tonight's discussion to be meaningful. To begin, I would like to introduce you to tonight's moderator, Dr. Harindra Wijeswara. Dr. Wijeswara is Chief of the Schulich Heart Program at Sunnybrook Health Sciences Center and an Associate Professor in the Department of Medicine and the Institute of Health Policy, Management and Evaluation at the University of Toronto. His research focuses on health technology assessments and economic evaluations in the area of cardiology and structural heart disease in order to inform health policies that provide equitable, effective, and sustainable health care to Canadians. We're very lucky to have him here to lead us through tonight's discussions. So without further ado, I'll pass the microphone over to you, Dr. Wijeswara.
Thanks very much, Colin, and good evening to everybody joining us virtually this evening. So tonight, our lecture will be an evening discussion on the heart, and as Colin mentioned, we're very fortunate that we have a great lineup of speakers for you from the Schulich Heart Program across our divisions of cardiology and cardiac surgery. We're going to start the evening with Dr. Idan Roifman, who's going to speak on COVID-19 and the heart, what are the knowns and unknowns of how the virus affects the heart. Then Dr. Mina Madden is going to present on SCAD, which, as Colin mentioned, is a different type of heart attack. And finally, Dr. Chris Tirola is going to talk about aortic surgery, the current guidelines and future directions. We've set aside quite a bit of time at the end of the evening for me to ask our panel of speakers questions that all of you have submitted. And thank you to those of you who have submitted a question online prior to the event. Please also feel free to send your questions during the talk through the website, and we'll make sure that we have those also. We have received quite a lot of questions, so we might not get to every one, but we'll do our best in the time that we have available. So to begin our event, I'd like to introduce our first speaker. So Dr. Idan Roifman is a cardiologist here at Sunnybrook Health Sciences Center. He's the medical director of our echocardiography laboratory, and he's a clinician scientist in the division. We're very glad to have him talk about COVID-19 and the heart, an area that he's done quite a lot of research in. And the title is The Knowns and Unknowns of How the Virus Affects the Heart. So I'll pass the mic over to you, Dr. Roifman.
Thanks, Harindra. So I'm just going to share my presentation. These are my disclosures for this talk tonight. And thanks to Harindra and to the Sunnybrook Foundation and everyone for inviting me to give this talk tonight. I thought we'd start with just a couple of objectives, just to keep us on track in the presentation. So we'll begin by reviewing some of the things that can happen to the heart in patients with COVID-19. I want to introduce a technique that I'm very passionate about, that I do quite a bit of research on, called cardiac MRI. and discuss how cardiac MRI can help us detect heart involvement in COVID-19. And then also discuss some of our research that utilizes cardiac MRI to evaluate the heart in patients with COVID-19. And this research is partially funded by the Sunnybrook Foundation. So we all know the magnitude of the COVID-19 pandemic. We haven't seen anything like this in 100 years. It's approaching 120 million affected worldwide, infections worldwide, and almost 2.5 million dead, which is astonishing. I actually just read an article that in the US alone, they're approaching 500,000 deaths and are likely to exceed that in the next few days, which is, if you think about it, it's more people than they lost in all of World War II in terms of soldiers. It's an amazing number. Cardiac involvement, which is also called myocardial injury, appears to be very common in COVID-19, but we don't have a lot of good evidence. Most of the evidence comes from relatively small case series. A lot of them have been published early on in the pandemic. There were a few that were published early on from Wuhan, which is obviously the epicenter of this, where it all started. And they reported about 20 to 30% of patients who were hospitalized for COVID-19 had some sort of cardiac involvement. Other case series have reported that cardiac involvement is associated with a significantly higher risk of death in hospital. And that's even worse when it's combined with a history of prior cardiovascular disease. So in other words, if you have a prior history of heart disease, hardening of the arteries, something along those lines, and on top of that, you get COVID-19 and you get hospitalized, then there is some emerging data that your outcomes are significantly worse. However, when we talk about cardiac involvement, it really is oh, it activated my Siri, I'm sorry about that. When you talk about cardiac involvement, it really is a vague phenomenon. What do we mean? It could mean multiple different things. It could mean heart attacks, what we call myocardial infarctions. It could mean myocarditis, which is inflammation of the heart. It could mean cardiomyopathy, which is a weakened heart muscle. And at this point, we don't know who gets what type of cardiac involvement. It's important that we do get a better understanding of this because this will lead us to better treatments and better outcomes for these patients. And cardiac MRI can help us differentiate between the different types of involvements in the heart. So let's shift over a little bit to cardiac MRI. And I want to give you a couple of introductory slides about it. And I will try not to get into too much of the technicalities and the jargon, but I do want to give you guys a bit of a base and then build upon that. So cardiac MRI is all about what we call sequences. So we have different sequences, which are little pulses of energy that we send to the heart. And based on these sequences, we get different information. These sequences can be broadly broken down into cine sequences, which are really movie images of the beating heart. And I'll show you examples of these. And this gives us an evaluation or assessment of structure and function. In addition to that, a huge value add for cardiac MRI is something called tissue characterization, which basically is a non-invasive molecular analysis of the heart. And there's different types of ways to do that. We can use something called late gadolinium enhancement to look at focal scar in the heart. We could look at myocardial mapping techniques to look at swelling in the heart or edema or diffuse scar. And this is an example of a normal patient. And this is the cine movie images that I talked to you about. And what I'm showing you here is the heart. You may have never seen it like this, but it's actually sliced like a loaf of bread in sequential slices. Okay, so think of each of these slices as a slice of bread. And that's how you're slicing the heart, which is longitudinal in shape. And we're looking at the heart here from the base of the heart, from all the way where it starts to all the way where it ends, what we call the apex. And with cardiac MRI, we visualize the entire heart. And because of that, we get beautiful images such as this. Most times, I'll talk about some times where we don't get beautiful images. And because we get these great images, it's considered the gold standard for the assessment of structure and function. In addition to that, we talked about the focal scar sequence. We could sometimes inject a contrast agent called gadolinium, and it gets injected in a standard peripheral vein, in a standard IV. And the idea here is that if you have a normal heart, the gadolinium will just wash right through and it'll look black. But if you have a heart attack, or if you have inflammation or swelling of the heart, you may have a focal scar that appears because the gadolinium gets trapped in the spaces of the scar, in the spaces of the water, the edema, and there's delayed washout, and that produces a white appearance. So black is normal, white is focal scar. And this is a slice that I'm showing you of like gadolinium enhancement sequence, the focal scar sequence from that normal patient. And I hope you can appreciate that, again, when you look at the myocardium, the heart, it's all black. There's no white areas. This white part here is just the blood pool that we saw in the previous image. And so this is normal. We can also use a technique called mapping, which looks at things like edema or swelling of the heart or diffuse scar. And here what we're actually doing is we're creating a color-coded map based on the amount of T2, which gives us the amount of water in the heart, or the amount of microscopic scar that we may not pick up with that focal scar sequence that I showed you before. So how do we use CMR to help us with COVID-19? This brings us to the project that we're currently doing at Sunnybrook. And the goal here is to look at what is causing cardiac involvement in patients with COVID-19, how often does it occur, what causes it, and we're going to utilize cardiac MRI to help to hopefully answer that question or shed light into that question. We also don't know who is at most risk of getting this cardiac injury. We know who's at most risk of dying. We don't know who's at most risk necessarily of getting the cardiac injury as a cause of death. And so we're going to look at potential things that would make people more or less likely to get that cardiac injury. And the idea here is that we're going to recruit patients, called a prospective multi-center study involving Sunnybrook, UHN, St. Mike's, and Southlake, but it's going to be centered out of Sunnybrook. The goal is to recruit 75 patients, and these are patients who were previously hospitalized with COVID-19, but have subsequently recovered. Each patient will have a cardiac MRI, and remember I showed you that cine movie sequence. They're going to have that to evaluate cardiac structure and function. Remember I showed you the mapping and the focal scar sequences. They're going to have that to look at tissue characterization. The other sort of angle that we're adding to this project is we're going to be performing both standard sequences and also testing a rapid imaging platform. Now, why do we need to test a rapid platform? So that brings us to some of the problems with traditional cardiac MRI. And this is one of them. And again, I don't want to get too much into the jargon, but one problem with traditional cardiac MRI is when patients can't hold their breath. And the reason for that is because traditionally, to acquire the images, the beautiful moving heart images that I showed you on the first couple of slides, you actually acquire those images over several heartbeats. And you only acquire a few of those slices. Remember those slices of bread, one or two of those slices of bread are acquired with each heartbeat. The problem is if you're unable to hold your breath, then the whole way that the MRI recognizes your heart goes awry. And then what ends up happening is you get these fuzzy non-diagnostic images such as this, and that defeats a lot of the purpose of cardiac MRI, which is gives us really good assessment of structure and function. Another problem is that it takes a long time because you have to ask the patient, okay, hold your breath. They hold it for about 8 to 10 seconds. You acquire a couple of slices, hold your breath again, 8 to 10 seconds, acquire a couple of slices. So this leads to very long scan times, and some patients may not be able to tolerate it. It could last for up to 60 minutes where they have to lay down flat. Because of these requirements, there's also reduced capacity, and that leads to long wait lists and other problems. So one potential solution is developing accelerated free breathing sequences. And we've already done some of this work here at Sunnybrook. This is an example of a paper we recently published where we validated an accelerated free breathing sequence that I'm showing you here on the left-hand side of the panel. On the right-hand side of the panel, we have the traditional sequence. And you can see the images look very, very similar. when we calculate the gold standard of heart function, which we call left ventricular ejection fraction, it was very similar in this particular patient. The difference is the patient with accelerated free breathing sequence, we got those images in about 20 seconds versus about 10 to 12 minutes just for the cine images for the traditional sequence. And when we calculated a bunch of other things that look at the volume of the heart, how much water the heart holds, how heavy it is, as well as its function amongst our cohort, we found there was no significant difference between the rapid sequence and the traditional sequence, with, of course, the biggest difference being that the rapid sequence is much more patient-friendly and it's much quicker and easier to do. So the next step to this is fully automatic MRI scanning. The way the MRI generally works is it's a multi-step approach, where the first step is to try to localize or find the heart, where the heart sits in the chest cavity. And then we perform different sequences. So we talked about the movie sequences, talked about the focal scar sequences, talked about the myocardial mapping sequences. All those are performed afterwards. This is extremely operator dependent and, again, time consuming. And to accelerate cardiac MRI, we could either do faster sequences, and I just showed you an example of that, or faster prescription and localization. And so we're actually working right now for a single button, one touch, comprehensive MRI protocol. The idea is eventually you press a button, it does the machine does everything for you, scans the whole heart, spits out the numbers, and you're done. We're not there yet, but that's the idea. And COVID-19 is actually a natural population to evaluate these technologies. Why? Because shortness of breath is very common. It's common sometimes months after they've had the acute infection. And a lot of these patients may have difficulty holding their breath, and they may not tolerate longer scans. So I wanted to end off by giving you a couple of slides about where we're at so far. So we've recruited and scanned about half patients that of our goal, 35 patients. And we've started to implement that fully automated scanning protocol. And these are some of our results. This is the first patient here. On the left-hand side, I'm showing you a cine image of the heart, the moving, beating heart. The images are quite good. And on the other side here, I'm showing you the late gadolinium enhancement images, multiple slices of that. The images are okay, but we could still improve upon them. But in this particular patient, you can see that it is a little bit grainy in here. We'd like it blacker, but it's good enough to be able to tell that there is no scar. Okay, compare and contrast it to what we call patient number 5. So this is a 61-year-old male who has high blood pressure and cholesterol, who was diagnosed with COVID-19 back in March and admitted to the hospital for COVID pneumonia. Didn't require ICU. It was a relatively straightforward admission. He was discharged, he recovered, discharged a week later, fully recovered at home, came off isolation. But he has nonspecific shortness of breath and fatigue that has persisted throughout. And he was recruited to the trial 6 months after the diagnosis. And these are his focal scar images. And I hope you can see here, it's pointed to by these blue arrows. There is a linear white area right there and there and there. And that's a focal scar. And this picture is very consistent with what you would see with myocardial inflammation or myocarditis. We look at the mapping images here, and basically what we see is that the mapping values are higher at the area of the heart where we saw the scar than they are in other areas of the heart. Again, supporting the notion that this is inflammation. We have inflammation of the heart muscle here, or myocarditis. The issue with myocarditis is that it puts you at risk for a couple of things. Number one is dangerous arrhythmias, or dangerous heart rhythms, what we call arrhythmias. Why? Because you have a little scar there, and that scar disrupts the natural electricity that flows throughout the heart and can cause new dangerous heart rhythms to form. The second risk is development of what we call heart failure over time, where the heart progressively weakens. Now, this case highlights the utility of cardiac MRI, because if there was no cardiac MRI with tissue characterization, we would never have picked up this abnormality. So the plan for this patient is to follow him up with serial clinical examinations and imaging and see how he progresses. So in summary, 3 points. Cardiac involvement in COVID-19 appears common, however, the studies are very small. We don't know what the nature of that cardiac involvement is and what the percentage of people who have each of these different types of cardiac involvement. Remember, it could be inflammation in the heart, it could be heart attacks, it can be heart failure. And we're working at Sunnybrook here to develop novel imaging tools using mostly cardiac MRI to better diagnose these patients so that they can be better managed. Thank you very much.
So thank you very much, Dr. Roifman. Really is such a topical area, COVID-19, and it is amazing, and you take a step back, how much we've learned about this virus and what it's done and what it does to the body over the last year. But as you've kind of highlighted, there's so much left to learn. And I'm always, although I've seen many pictures of the MRI images that you've done, whenever I see them, I'm always taken aback about how much like a science fiction movie it looks like, of what we're able to tell about what's happening on the inside of the body using these different types of imaging. So thank you very much. I'd like now to introduce our next speaker, Dr. Meena Madden. So Dr. Madden is an interventional cardiologist, and she is the medical director of the cardiac cath labs here at Sunnybrook. Now, in addition, she is one of a handful of experts who work on a very different type of heart disease called spontaneous coronary artery dissections, or SCAD. And she's going to be speaking to that to all of us today. So thank you very much, Dr. Madden. Over to you.
Thank you very much, Harendra, for the kind introduction. I'm just going to work on sharing my screen first off. All right. Okay, great. So I'm really excited to speak to all of you tonight at this great session. I'm excited to speak about SCAD and my efforts to start a clinic for SCAD patients in the past 18 months. And it's really become a passion project for me, born out of a need to understand this condition much better, and also improve the lives of patients and raise awareness in the medical community and the public for this different sort of heart attack. So maybe just by way of background, the best place to start is to talk a little bit about the burden of heart disease in Canada and a little bit about an actual traditional type of heart attack first. So as Colin mentioned, heart disease in Canada is the second leading cause of death among Canadians behind cancer. And about 1 in 12 Canadians will be diagnosed with heart disease in their lifetime. And every hour, 12 Canadians will die of heart disease. Now, heart disease affects men and women differently, such that men are 2 times more likely to suffer a heart attack than women. And every year in Ontario, we have about 20 to 25,000 patients coming to hospital with heart attacks. Now, men are usually diagnosed in their mid-50s to mid-60s, and women present a bit later, about 10 years later, from their mid-60s to mid-70s. The good news is, though, that death from heart attack has been on the decline for at least the last decade, if not more, and that's good news. Now, what you can do to reduce your risk of heart disease is be smoke-free, stay physically active, even during a pandemic, eat a healthy diet to keep a healthy body weight, and limit alcohol use. Now, early detection and management of risk factors like high blood pressure, diabetes, high cholesterol can really go a long way to keep you healthy and reduce your risk of heart disease. All right, so let's start by looking at what is a heart attack, or the fancy medical term that Idan mentioned, myocardial infarction, or MI, as we like to call it. So in terms of the basics, the heart is a muscle pump that sits in the left chest, and it pumps to supply blood carrying oxygen to the rest of the body. The heart itself, though, has its own blood supply, and these are blood vessels that sit like pipes on the outside of the heart muscle. Now, in certain people, cholesterol plaque can develop, like shown here in this cartoon, and grow over a lifetime. If this plaque should suddenly rupture, the blood vessel can close abruptly, and that's a heart attack. And slowly, slowly, heart muscle starts to die. Now, we can limit the amount of damage that's done by performing an emergency procedure called a coronary angiogram to diagnose where's the problem, what is it, and then try to open the blocked artery with a balloon and a stent. And you should know that Sunnybrook has one of the largest heart attack programs in the GTA. So what are the symptoms? Well, both men and women can experience chest pain, shortness of breath, and the pain can actually radiate to other parts of the body. Now, in women, it's now well recognized that they can have atypical symptoms that we need to be on the lookout for, and they're shown here. So if we roll the clock back to 2003, we were still looking for Saddam Hussein. And this Time magazine cover was one of many journals and magazines that sounded the alarm about women in heart disease, and was really trying to get women to be engaged, to recognize that heart disease is an important killer of women, that patients need to take care of their heart health, and that they need to seek attention for medical symptoms, for chest pain and other symptoms. And one of the most iconic campaigns is the Go Red for Women campaign launched by the American Heart Association, and they use the symbol of the little red dress. And over the years, this has evolved to a Wear Red campaign that takes place every February during what's traditionally felt to be Heart Month. And this is a banner from the Heart campaign in Canada that just passed a few days back. In more recent years, the focus has shifted to the importance of heart disease and heart attacks in younger women. So let me introduce you to a few patients. This is Kelly. She had spontaneous coronary artery dissection at age 38. Her day started off as a normal Saturday, dramatically changed. She was the mother of 3 beautiful children, a very high intensity exerciser, and she had a SCAD-related heart attack. These women also had a SCAD-related heart attack, and they look just like your mother, your sister, your friend, and your neighbor. These patients also had SCAD-related heart attack. And here they are with their families at a research fundraiser. And this is in Australia, actually. So doesn't that look nice at this time of the year in Canada? So here's another patient. In this case, the SCAD patient is the dad. And you can read about Brian's story because he posted it on Facebook. So let's talk about a few SCAD facts. So SCAD is the #1 cause of heart attacks among women under the age of 50 and those who are pregnant or who have just given birth. Most SCAD patients are healthy, active, young women. The heart attack occurs in their 30s, 40s, and 50s, but it has been described in both younger and older populations. And SCAD can affect men too, in about 10 to 15% of cases. Many SCAD patients, if not most, will also be found to have an underlying blood vessel disorder that predisposes to the arteries being a little bit weaker or frail. And this condition is called fibromuscular dysplasia, or FMD. What we know about SCAD is that it's not due to cholesterol buildup. It's not traditional coronary artery disease, and usually affects patients without any risk factors or very few risk factors. And conservative treatment is often best, and what I mean by that is no stent for the vast majority of cases. The arteries often heal without any intervention. And as awareness and diagnosis has increased, the medical community is realizing this condition is not so rare after all, and we are getting better at making the diagnosis. How are patients diagnosed? Well, patients typically come to the emergency room with chest pain, and they have an ECG done that's abnormal, and cardiac troponin elevation in their blood, which is consistent with heart muscle injury. A diagnosis of SCAD as the particular type of heart attack is made by a certain appearance at the time of the coronary angiogram. The good news is more than 90% of people do very, very well treated in hospital. So here's a cartoon showing the mechanism for SCAD. In the top panel here, this is a normal blood vessel. Now, one mechanism for SCAD is a tear, a sudden spontaneous tear in the blood vessel lining so that blood can get around the tear, but also under the tear and into the wall of the artery, and blood can collect there. The second mechanism is that the blood vessels themselves have their own blood supply, and a spontaneous bleed into the wall by one of those blood vessels bursting can lead to accumulation of blood and compression of the artery from the outside in. And this is in contrast to the traditional cholesterol plaque buildup, so quite a different situation. This slide is just to remind us that when a woman comes to the emergency room or a patient comes to the emergency room with SCAD, they are really indistinguishable from patients suffering traditional heart attacks. They too have chest pain radiating to the arm, nausea, sweating, shortness of breath, so on and so forth. Let's look at a case or two. Here's case one, a 34-year-old woman who's 6 months postpartum. She came to our emergency room with 8 hours of chest pain. She has a past history of migraine headaches, no cardiac risk factors. She had abnormal blood tests, abnormal ECG, and a quick look echocardiogram showed the tip of her heart was not contracting strongly, and the diagnosis was a heart attack. Here is her coronary angiogram, and this is an angiogram of the left anterior descending artery. Now, put quite simply, this black line, which is X-ray dye filling the artery, should be roughly this thickness throughout, maybe slight tapering, but not this abrupt tapering that I'm pointing out here with a very thin line going forward here, from here to here. So that is the spontaneous coronary artery dissection. The right coronary artery looks very smooth and normal. Another case, 43-year-old woman, smoker, came to our emergency room with 1 hour of severe chest pain, trouble breathing, profuse sweating, past history of migraine headaches, taking oral contraceptives. Her heart attack involved the front wall of the heart, and again at angiography, we expected to find a problem with her LAD. And indeed, that's what we found. A long segment of tapering in the mid part of the vessel, and here too the diagnosis was SCAD. So 3 days later, unfortunately, this patient experienced more chest pain and more ECG changes. And the diagnosis here was propagation of SCAD, both forward down the artery and backwards up the artery, and a new vessel also had developed SCAD. Now, I followed this patient for 5 years since that time, and she's doing extremely well. I spoke with her last week, actually. Here is her angiogram 3 months after follow-up. So this is the in-hospital that I just showed you, this thin thread, and you can see that the artery has completely healed by 3 months later. And this is because the blood in the wall of the artery and all the tissue that was torn has healed up on its own. Sometimes it's not so easy to make the diagnosis with the angiogram, and when we're uncertain, we sometimes need other imaging modalities to make the diagnosis. So optical coherence tomography, or OCT, is another type of imaging, and it uses infrared light to provide high definition imaging of the inside of the artery. Now over here in panel C, I'm showing you what a normal artery looks like. Here's the imaging catheter and a artifact caused by the guide wire. And there are 3 layers of the blood vessel that we see here, and this is the opening of the blood vessel, the black. In this case, we see that part of the opening of the blood vessel is occupied by this collection of blood or bruise in the wall of the artery. And indeed in panel A, we can actually see the site of the tear. So pretty dramatic picture. SCAD typically occurs because there is an underlying condition such as fibromuscular dysplasia or pregnancy-related or an inflammatory disease like lupus or Crohn's or some kind of connective tissue disease. and some kind of precipitating stress like intense physical exertion or intense emotional stress. It was previously thought to be quite rare, but I think we were simply underdiagnosing it. As I said before, the diagnosis is made on coronary angiogram, and there are 3 types of SCAD patterns that we can recognize on angiogram. And that was described by one of my colleagues at the University of British Columbia, actually. So we have a Canadian international SCAD expert that we work very closely with, actually. So the treatment of SCAD is conservative therapy. So what I mean by that is not fixing the artery, and that is preferred over stenting because healing does take place in well over 80% of cases. And just to expand on that a bit, if you can imagine if you were to squeeze on a tube of toothpaste like this, you would extrude the toothpaste in both directions, forward and backwards. So if you can imagine pressing with a stent on the wall of the artery that has blood in it, you will extend the tear both forwards and backwards and creating quite a mess in that artery, and it's very difficult to solve this problem once the tears are extended. So, but sometimes we do have to intervene, and it's with a lot of trepidation, and sometimes the patients need angioplasty. Other times when the tears are in tricky areas or the collection of blood is in a dangerous location, we need to intervene with cardiac surgery. So healing does take place, and I'll show you a couple of examples. This is a patient of mine who had, again, the front wall artery involved with this area of abrupt narrowing that has completely healed 8 weeks later. Here is another example. This is another patient of mine. That's funny, I actually talked to her today. But a year prior, she had an area stented in her right coronary artery. And what I suspect is that at another hospital, they had not recognized that she may have had SCAD. But 1 year later, she showed up with another heart attack. And indeed, this was the area in question with SCAD in the middle of the left anterior descending artery. And then again, on imaging, re-imaging, 6 to 8 weeks, this was about 6 to 8 weeks after a heart attack, the artery has again largely healed itself. So this is kind of a treatment pathway that we've established for patients in our SCAD clinic. Patients are sent home on low-dose aspirin and a type of medication called beta blockers. A second antiplatelet drug is typically only needed if a stent was added. And we feel that there is no role for cholesterol-lowering drugs called statin because, as I explained, this is not a cholesterol disease. We need to screen broadly from head down to the pelvis, looking for blood vessel abnormalities like fibromuscular dysplasia, and sometimes we find aneurysms, and CT angiography is the best way to do this. We encourage all patients join cardiac rehab. We screen for inflammatory diseases very selectively, and genetic testing also very selectively. Unfortunately, there's no 23andMe that you can send off for SCAD. You can't spit into a cup and send it somewhere and get a diagnosis back. Currently, there's a lot of research going on, and there might be a genetic basis, but it's all very much the subject of research right now. So SCAD has a strong association with fibromuscular dysplasia, and what I mean by that is this kind of roller coaster or tortuous zigzag coronary arteries, or corkscrew tortuosity is the other term. Now, fibromuscular dysplasia is also present in the kidney arteries. Here is this so-called classic beads on a string picture, or this lumpy, bumpy kidney artery, and here also in the carotid artery in the neck. Sometimes it's referred to as a stack of coins. Here is a patient of mine with a lumpy, bumpy kidney arteries, left and right, shown here with the red stars. And here is another patient who has a more subtle finding, which is this rippled appearance of her leg artery. That is also FMD. Here is a patient with a very, very tortuous arm artery, as well as FMD in the leg and FMD involving the kidneys here. a word about recurrence. So the recurrence rate of SCAD is 10% or by 3 years, or 3% per year. To put that in context though, a traditional heart attack patient who gets a stent, who gets all the best medications and follow-up, has a recurrence rate of another heart attack that is roughly about 6% by 1 year. So the recurrence rate for SCAD is lower. We ask the patient to make some lifestyle changes, such as avoiding heavy lifting, and engage in only moderate intensity physical activity. We also ask patients to maintain the blood pressure in the normal to low normal range, to remain on beta blockers long term, as this appears to be protective. And women of childbearing age are asked to avoid pregnancy, as the recurrence rate has been about as high as 14% in some series. A word about SCAD in men, as I mentioned, it's 10 to 15% of cases, and almost half of men report some very strenuous form of exercise, lifting more than 50 pounds, or severe emotional stress. Sometimes there is associated inflammatory conditions like ulcerative colitis, and a large proportion do have FMD as well. We had a chance to get involved in the Canadian Spontaneous Coronary Artery Dissection Study, which was a large study under the leadership of Dr. Jackie Saw at UBC. And we enrolled 750 patients over a 4-year period at 20 centers in Canada and 2 centers in the US. And the main findings of this natural history study for SCAD is that the average age was 52 years. Most patients were female. A third had high blood pressure, and a third had no risk factors at all. And 1/3 had migraine headaches, and 1 in 5 had a history of either anxiety or depression. About half of the patients had an emotional stressor before the event, and a third had an unusually intense physical stress. About a third of patients had fibromuscular dysplasia, but I can say that at least half the patients had incomplete screening. And I think what we're seeing is that you find it more and more when you look carefully. And despite conservative therapy, so not stenting, in the vast majority of cases, the survival was excellent, almost 100% at 30 days. There were some recurrent heart attacks, and some patients, very few, had to have angioplasty or surgery. And peripartum SCAD was particularly high risk. So this cohort is being followed up, and we're adding to that series with the next phase of the study, which is to accumulate an international experience of 3,000 patients. I wanted to finally finish up with mentioning our Sunnybrook SCAD clinic website. We went live a few months ago, and there is a referral form for patients' physicians to fill out and fax to us. And just a small word about our donations. We are doing a number of projects that will help understand the history of SCAD and outcomes, and try to tailor therapies specifically focusing at SCAD patients. So if this talk resonated with you and you have family members or friends that want to support women's health initiatives, we would be very grateful. So I will finish up there by saying that spontaneous coronary artery dissection is an illness that represents a very complex interplay between underlying conditions that predispose to blood vessel frailty. And usually we have also emotional and physical stressors to be aware of. We have a lot to learn. We've learned a lot so far, but I think that focused research in this area will yield some very novel solutions, and I'm optimistic. Thank you.
Thanks very much, Dr. Madden. A very comprehensive overview of a topic that reassuringly is becoming increasingly recognized. Just a reminder to everybody who's watching, we will be conducting a Q&A session after the final lecture and hope to answer all your questions. So we have received some more questions during the talk, so please continue to send them in through sunnybrook.ca/speaker series. So I now have the pleasure of introducing our final speaker for the evening, Dr. Chris Tirola, who is our newest recruit to the Iliac Heart Program in the Division of Cardiac Surgery. So he is a cardiac surgeon who does traditional cardiac surgery and two slightly different things. He's a cardiac surgeon who not only does surgery through the typical big cuts of cardiac surgery, but also through much smaller, minimally invasive cuts. And the second area of his expertise is in the big tube that leads out from the heart, or the aorta. And that's what he'll be speaking about today. He'll be discussing aortic dissections, the great masquerader. So thanks so much, Chris, for being here, and over to you.
Okay, thank you very much for the introduction, and thank you to everyone who joined us tonight. Congratulations to you all for joining us for an important series of talks. And I think, as Colin mentioned, a lot of attention has been put on COVID-19, but I think it's important that we don't lose sight of the other medical conditions that can affect our health as well, important being heart disease. And so what I'd like to talk to you about is something related to the cardiovascular system, an aortic dissection, and we'll learn about what that is. We'll learn about what the symptoms of it are, how we treat it, and why we in cardiac surgery refer to it as the great masquerader. So just a little bit about myself. I did my training at the Iliac School of Medicine at Western. During my residency in cardiac surgery there as well, I did a master's of public health at the T.H. Chan School of Public Health in Boston, and then completed a fellowship in advanced aortic surgery at the Cleveland Clinic. My research interests are clinical outcomes in aortic surgery, aortic dissection, aortic aneurysms, and innovation in minimally invasive aortic interventions. And I bring this up because right now is an extremely exciting time in aortic surgery, because we're finding new ways to treat people with aortic dissections and with aortic aneurysms in a less invasive way, which allows them to have a shorter recovery. And so there's a lot of research going into that, and research that we're hoping to be a part of and that we're initiating. And so I'm excited to be able to talk to you and present about this. And so I'm just going to slide this over here. Okay. And so first thing we need to talk about is what exactly is the aorta. And so the aorta is the main artery that carries blood away from the heart. And it's the big tube from which the majority of the other tubes originate that carry blood to all of our organs, our brain, our bowels, our arms and legs. And this is just a schematic of the heart that shows it originates from the left ventricle, which is right here, and that's the major pumping chamber of the heart. This is the aorta coming out of the heart, and you can see it's dilated here, secondary to an aneurysm, and we'll talk about what that is in a second. And we can see the aortic valve, which sits right there and separates the major pumping chamber from the aorta. And there's four segments to the aorta: the ascending aorta, which comes up out of the heart, the arch of the aorta, and that gives off the branches that go to our head and to our arms. The descending aorta, that comes down through the chest and runs along our spine. And then the abdominal aorta, and that gives off the branches that go to our kidneys and to the organs in our belly. So what is an aortic aneurysm? When an aneurysm can occur in any artery, and it's an abnormal enlargement of that blood vessel because of a weakness in the wall. And sometimes there's a predisposition to it, which we'll talk about. And so when that weakness occurs in the aorta, then it causes an aortic aneurysm. And there's two types of aneurysms: true aneurysms, which involve all the walls of the aorta, and false aneurysms, which involve only some of the walls. And so we'll talk about the true aneurysms and where they can occur. And so in this picture, we can see they can occur generally along the entire length of the aorta. Some people in only a select location, and other people, sorry about that, and other people through the entire course from where it starts all the way to where it ends. And so you can see how that could be a problem that is a big problem and something that that's important to treat. So aneurysms, like I said, can occur in any artery of the body, whether that's the ones that go to the kidneys, to the brains, to the bowels, or the legs. And they can occur along the entire length. So we have a root aneurysm. So if we go back a couple of slides here, If the aneurysm involves this portion of the aorta, which is called the aortic root, the aortic valve, and the portion where the coronary arteries come off, then that would be referred to as a root aneurysm. And we'll talk about why that's important. The ascending aorta, which comes straight up the arch, or the abdominal or descending aorta. And it's important to know that because that can give us a little bit of a hint as to what type of an aneurysm a person can have based on their symptoms. For example, if they have an aneurysm in the root, then that can involve the aortic valve. So as you can imagine, the aortic valve is sitting inside of a tube, and as that tube dilates, the doors that open and close when the aortic valve or when the heart beats can pull apart, and that can make the valve leaky. And when the valve becomes leaky, somebody can get short of breath. And so these are the little hints that we have that tell us exactly where an aneurysm might be. How many people have aortic aneurysms? So they're more common as we age. And they are surprisingly responsible for quite a few deaths each year, whether that's in the United States or Canada, and I've included those numbers. They occur in roughly 5% of individuals over the age of 65, and that's for aneurysms of the abdominal aorta. And about 0.1 to 0.5% of individuals have some kind of dilatation or aneurysm of the aorta in their chest. And so we can see that that's fairly common, although most people aren't necessarily aware of that. It's within the top 15 causes of death in people over the age of 55. And so it's important that we continue to do research and to innovate in order to improve survival with these, with aneurysms, and eventually what we talk about are aortic dissections. And the other important thing is that these numbers are likely underestimated. So as we'll find out, aortic aneurysms and dissections can present in a variety of ways. And sometimes we don't necessarily recognize the aortic aneurysm or dissection as a cause of a complication, but rather recognize another cause. And so when we capture this data about what causes death or what causes different medical conditions in people, an aortic dissection or aneurysm might be the cause, but isn't necessarily noticed. So who's at risk for aortic aneurysms, or how can we get them? And so we've talked already about a number of risk factors. And these are risk factors that are very similar to those that cause heart attacks. And so that's because they're cardiovascular risk factors. So they affect both the heart and the vascular system, the aorta being part of that. Some of those risk factors include high blood pressure or hypertension, smoking, and high cholesterol. And so it's very important for us to monitor those and to keep them under control. And the other common question is are these genetic? And I do get that question every once in a while in clinic, actually fairly frequently. And the answer is sometimes. So there's a number of genetic conditions that can predispose people to aneurysms. The most common one that you might have heard of is Marfan syndrome. And that encompasses a group of people who have features like very, very long arms, very long legs, they're very tall. They sometimes have some deformities of their chest. And so in those kinds of situations, it's important that all the members of the family are aware of that diagnosis. And just to kind of give you an idea of some of the research that's going into this, a lot of people have spent time trying to identify these syndromes that I have listed here, but also other ones that don't necessarily have a name, but they're a gene mutation that can predispose somebody to aneurysms. And so these are just a general sketch of the ones that we've identified so far, and somehow these have been linked to the development of aortic aneurysms. So how do we know if we have an aortic aneurysm? So aortic aneurysms are usually asymptomatic. So usually the case that happens is that people present to hospital, they have a CAT scan for some reason or an ultrasound for some reason, and incidentally, we find an aneurysm located in their chest, in their belly. And so that's generally how people tend to present. And then we start to follow the aneurysm after that. Some people, however, can have symptoms, and those symptoms, again, depend on where exactly the aneurysm occurs. So like we talked about root aneurysms before, when the aortic valve begins, the leaflets or the doors that open and close begin to pull apart, that valve becomes leaky, and that can cause shortness of breath. In the aortic arch, the nerves that supply our vocal cords run in that area. And so an aneurysm in the aortic arch can cause hoarseness or difficulty swallowing. And so these are some of the hints that we have that somebody might have an aneurysm, but in general, people tend to present because they were found on a scan for something else. And so what I have here in this picture is a CAT scan, just a single view. And this is like Dr. Rothman was speaking about before, about slices. So this is a slice of a person's chest. And we see A here is the ascending aneurysm. So that's A for ascending aorta coming up out of the heart. And we can see compared to the descending aorta, which is going back down towards the legs, the difference in the size between those two. So the D is probably what's normal, whereas the A is much significantly larger. So the next question is, okay, I have an aneurysm, when do we fix it? And there's two main situations that we fix aneurysms. The first is when they meet certain size criteria, and we'll talk a little bit about how we got to those criteria. And the second is when we have a complication, and that's where the concern for aortic dissection comes in. So when these aneurysms reach a certain size, so depending on the location of where they are, the size varies, but in general, it's about 5.5 to 6.5 centimeters. We try to operate on them in order to fix it. And for people with genetic conditions like Marfan syndrome that we discussed earlier, we sometimes operate earlier because their risk of having a complication is a little bit higher. If we're not at that size, then we just follow with repeat images, whether that be a CAT scan or MRI scans. And so this is where those numbers come from. So back in the late 1990s, there were some studies done that looked at the risks of continuing to watch an aneurysm and when we get one of those complications that we were discussing. And we found that generally the risk increase of a complication increases at around 6 centimeters for aneurysms of the ascending aorta and around 7 centimeters for aneurysms of the descending aorta. And so we try to operate when they're lower than that, although it's not uncommon for us to, for the first scan in somebody to show an aneurysm that's bigger. And why is it so important to detect aneurysms? So why do we look for all of these little clues? Well, the reason for that is because we see this curve here that shows the differences, that shows time on the bottom and overall survival on top. And we see the difference in elective surgery and emergency surgery. So the emergency surgery is when people come in with an emergency like a dissection or a rupture, and elective surgery is when we operate on these aneurysms before that happens. And we can see that there's quite a difference between the two. And this data is actually from probably the late 1990s, early 2000s. And so this curve is actually probably even a little bit better than that now. And that's part of why this is such an exciting time in aortic surgery, is because we're starting to straighten out the curve for elective surgery and reduce the risks associated with aneurysm surgery. But we're also starting to improve the outcomes for people that have emergency surgery. How do we fix aortic aneurysms? So the general way, so there's two approaches. There's the open approach, which I have here on the right, and an endovascular approach, and we'll talk about those in a second. So what we do is we, in an open approach, and this is usually for the ascending aorta, so the part that's coming out of the heart, is we replace that aneurysm with a synthetic polyester tube, which is what we call Dacron. And that Dacron is an excellent material in that it causes very few reactions in the body. It's very easy for people to tolerate, and it's coated in a special film so that it doesn't leak. The other option, though, which is the focus of part of my research and innovation in the field, is endovascular surgery. And so this is a stent where the Dacron graft is loaded onto the stent. And so we use a small catheter, which is about the size of a pen, and we insert it into the arteries in the groin and advance it across the aneurysm. And then the stent expands. and that blocks off blood from entering either above the aneurysm or below the aneurysm. And that way we can repair these aneurysms using a more minimally invasive approach where we don't have to open up somebody's belly and reduces their long-term or their surgical recovery time. So this is where some of the biggest cardiac and vascular problems occurs. What happens if we don't fix aneurysms? And so that can be quite a big problem. Both situations require emergency surgical repair, and there's two main things that can happen. One is a rupture of the aorta. So that's when the wall becomes, or the aneurysms become so big that as it continues to grow and absorb that stress, it becomes thin enough and weak enough that it breaks, which allows blood to flow to surrounding structures. And that requires emergency surgery. In the abdominal aorta, the option is to have open surgery or to have an endovascular surgery. Both options are available depending on where exactly the location is. But for the ascending aorta, we don't have that technology, and that's part of what I'd like to get involved with. And so we come to the second complication, which is the great masquerader, an aortic dissection. And we'll talk about what exactly an aortic dissection is. And we've already learned about coronary artery dissection, so the mechanism is similar. And we'll learn about why we call it the great masquerader. So what is an aortic dissection? To understand that, we have to know that there's three layers that make up any blood vessel. And for an artery, when the innermost layer gets a little tear in it, like we just learned, sorry, my mouse is not cooperating, blood can track in between those layers. And so you get what's called a true lumen, where the blood is supposed to flow, and a false lumen, which is where the blood is now tracking through the tear. And that can occur anywhere along the course of the aorta. When it happens in the ascending aorta, the part that comes out of the heart, then you would see a cardiac surgeon. And when it happens in the descending aorta, which is the part that comes after the arch, so when it takes a turn to come back down through the body, then you tend to see a vascular surgeon. And so why is it called the great masquerader? It's because an aortic dissection can present in a whole number of ways with a number of faces and a number of different symptoms. So some people can have chest pain. Some people say that they have a lot of tearing back pain, abdominal pain. Some people can present with paralysis or a stroke. And so because of all those faces, we have to have we have to be suspicious and make sure that when somebody comes to hospital that we've ruled out all the other causes that could potentially be leading to their condition. And so I have a picture here that shows an aortic dissection, again, a CAT scan, and you can see this that's a little bit brighter is the true lumen, and you can see the tear here. So there's a space between this part of the inner layer of the aorta and this part of it, and blood is tracking across that tear and filling up this area. And so for a little bit of relevance, this is a study that came out of New York for patients who present with aortic dissections and looks at how many cases they had before COVID and after COVID. And they found that there was a significant decrease in the number of people that were presenting. And it's important because these patients didn't stop developing dissections. They mostly are not presenting to hospital because of a number of concerns, whether that be not wanting to come to the hospital for fear of contracting COVID, or for not wanting to come for fear of, or for thinking maybe they have it, or that the symptoms are related to something else. And so it's important for us all to be aware of our risk factors for aneurysms, and particularly if you have an aneurysm, then to know that if you develop sudden onset of pain or symptoms that you've never had before that are severe, then this is potential. So there's two types of dissections, a type A dissection and a type B, which I've kind of alluded to already. And a type A is when you see a cardiac surgeon. So it's a dissection that involves the ascending aorta and requires open heart surgery. And we can see here why it's so important for us to detect these early, because the mortality or the risk of a serious complication after the dissection happens starts at 1% or increases by 1% every hour. And so by a week out, you can, or even a few days out, you can see how high that number can get. And it requires urgent surgical repair. The complication rate of surgery is quite high. So we showed before that that big difference between elective surgery and urgent surgery or emergent surgery, and to repair an aneurysm electively has a complication rate in around 5 to 7%, whereas for aortic dissection it's around 40 to 50%. So we need to have that index of suspicion, and that's important for us physicians to have when you're presenting to the emergency department or to your family doctor with new symptoms. And so that's why detection is essential. First, so that we can recognize it early to treat it, and second, because detection of the aneurysm is essential so that we can avoid that situation. Type B aortic dissection, unlike the ascending aortic dissection, can be treated usually medically, but if there's a loss of blood supply to a major organ or to a limb, then we can treat it endovascularly. So these are those special stents that are loaded on top of catheters that when we deploy them, they expand and cover up that tear, allowing the aorta to heal. And so these can be delivered through a puncture in the groin. The other thing that's important to keep in mind, though, is that dissection can cause residual weakness in the aorta. And so I'm presenting this slide just to show, mostly as a precursor to the next slide, to show you how some of the advances that we have. And so when the whole aorta becomes weakened and becomes aneurysmal, then we have to replace a fairly large portion of it, as you can see here. And that requires a large incision. And so our goal with ongoing research is to make this a smaller, or to approach these in a more minimally invasive way in order to reduce the recovery time. And so this is where things become interesting. And I'm just going to leave everyone with a few concepts of where aortic surgery has started and come. So this is a new device that's been around for the last decade or so that's called the Thoraflex. And so this is a device that allows us to treat aneurysms of the arch and the descending aorta all at the same time. So what we had to do in the past was basically in the operating room, sew all these pieces together and then use it. But now it's been developed to come all as one piece. It has branches that are pre-made, and they go to the arch of the aorta or to all of those head and arm vessels. And it has this graft here that actually has a stent in it, and that allows us to treat an aneurysm that might be at the beginning of the descending aorta. And so we can treat the whole thing all at once. This is another device that's called the AMDS, and it's a device that is an uncovered stent. So the previous Thoraflex had a covered stent on it. This is an uncovered stent. And so when somebody comes in with a type A dissection and needs open heart surgery, then we can deploy this stent in order to try to heal the aorta, in order to prevent them from having that aneurysmal degeneration of the aorta that I was talking about before, where you need a much more invasive open surgery. And so this is actually just completing early clinical trials, and it's a device that we're excited to be able to be using and to continue to complete research on. There's a number of these new stents that have been developed over the course of the last few years. So initially stents would come as just a single tube, and now we're starting to have these branches that come off, and these branches allow us to treat again the aortic arch and the abdominal vessels using a single procedure instead of multiple procedures. This shows an image of what we call fenestrated grafts. So these are single tube grafts that have separate holes for each blood vessel that goes to the kidneys and to the abdominal organs. And so this is a minimally invasive approach to treating those big aneurysms that take up the entire aorta that I was discussing. And granted, these devices are not yet perfect. They still require some fine tuning. They're still in their infancy, but this is part of the research that we're trying to do in order to make these much more generalizable. This is a brand new stent that I worked with during my fellowship in Cleveland, and it's come out just within the last couple of years. And it's a special dissection stent. So when somebody comes in with a type B aortic dissection, or one that involves the aorta going down to the legs, this is a stent that can be deployed in order to try and push the walls of the aorta back together, and again allow it to heal and allow them to stick together so that you don't develop an aneurysm down the road. And so this is a device that we're looking to obtain research grant for, to further investigate it. This is a device that shows all the different components that we can use. And finally, something that is kind of on the newest frontier is to try and treat those ascending aneurysms with a stent graft. And so that hasn't been done, or sorry, that's been done only recently, within the last couple of years, but it hasn't been approved as an official, as a regulatory device yet. And so this is where a lot of research is going into, and hopefully research that we'll be a part of in collaboration with other centers, especially across Toronto, and helping to design and develop these devices in order to treat ascending aneurysms, ascending dissections, which are currently only treatable by open surgery. And so this is why all these devices coming out within the last few years that are all helping to change the way that we do aortic surgery, and it's ongoing research and support that is helping to significantly improve the outcomes of patients with this disease process, but also improve their recovery and improve their overall survival. So thank you very much for your attention.
Thank you very much, Chris. Really a great glimpse into an important condition, but also highlights one of the key areas that the Schulich program really focuses on, this area of innovation. And you've highlighted a number of areas that we'd like to participate on, really being at the cutting edge. I think for everybody on this webinar, it's really important to recognize, despite the pandemic, that heart disease doesn't stop. And that's really been highlighted by the talks that you've heard, and that it's important not to delay seeking out that medical attention. So with that concludes our formal presentations for the evening. And now we're going to begin the question and answer portion. So I've received quite a few different questions, and I've tried to group them a little bit, but we are going to kind of jump so that all of our speakers get a chance to participate. So the first one is going to be on COVID, and I'm going to direct this to Dr. Reufman, but after he answers, Dr. Madden and Dr. Tarola, please feel free to jump in. So the question is, we are often, or daily, we get numbers on the number of COVID patients who have been hospitalized or died. And are the number of patients dying of heart problems included in that? And do we have a sense of what's happening to heart disease and heart disease deaths during COVID? So Adan, do you want to comment on that?
Sure. So it's a very good question. Initially, when the pandemic was in its first phases, some of the naysayers were saying, well, this will replace flu. It's just a worse flu. It's nothing more than that, or a bad flu year. And it turns out that overall, we could look at something called expected mortality, which is the number of people that we expect to die every year, which has been fairly, it's going down gradually as we progress and advance, but it's been fairly consistent over the past 10 years or so. And that expected number is much, much higher this year. To the point, I think Alberta released data that this was a couple months ago, before they even hit the peak of their second wave, that they've had more people die of COVID-19 in this year than they had in flu for the past 12 years. So that just gives you a little bit of an introduction. When it comes to differentiating between those who die from heart attacks versus those who die from other things, it is a bit more complicated. But there have been some studies in the States that have attempted to look at that with Medicare data. And what they concluded was that the cardiovascular mortality, so people that die from heart attacks, actually increased as well during COVID. So overall mortality increased the most, which I talked about initially, but cardiovascular mortality, death due to heart attacks, other cardiac reasons, also increased as best as they could discern. And so what are the reasons for that? Well, one potential reason is what I talked about in the focus of my talk, which is cardiovascular involvement with COVID. But another equally worrisome reason was brought up by Chris and Harindra, which is that, people did not stop having heart disease and heart attacks for other non-COVID related causes just because there's a pandemic. But there was a while in which the amount of heart attacks, serious heart attacks in the States was reduced by a dramatic amount, and same with Canada. And it wasn't because people were having less heart attacks, because they were waiting at home and unfortunately dying at home. So I hope that answers the question. More deaths overall by a huge majority. So COVID is having a massive impact, and I would challenge anyone who would say otherwise. But in addition to that, there's also more cardiovascular death. Part of it due to COVID, part of it probably due to waiting for diagnosis and treatment.
So maybe I'll ask the same question to Dr. Madden, and maybe if you could reflect in your role as the director of the cath lab, what you've seen and any concerns over the course of the pandemic as far as heart attacks.
Sure. Actually, if I could just share one slide with the audience, which is here. Can you see that? This one. So this speaks to March in New York City last year versus in last year compared to the year before, 2019, and cardiac arrest 911 calls. And this is kind of a stable low rate that occurs, or a certain rate that's steady in the population. And these cardiac arrest calls dramatically peaked from March to April in New York, as did cardiac arrest deaths as COVID-19 was peaking in New York City. And I think as the world was watching, and we didn't know what would happen in Canada. And I can say that in the cardiac cath labs, what we've seen is initially in March and April, we were seeing very few heart attack patients coming. And those who did come to the hospital often commented to us that the pain was so bad they couldn't take it anymore, and they were terrified of coming to the hospital, and they waited as long as they could, which is the absolute wrong message that we didn't want to have out there. Is more, I think we've evolved over time to say we are here for you, we are ready to receive you, and you shouldn't hesitate to seek medical attention for your symptoms. But despite that, I think although our heart attack numbers have gone back up a little bit, we're still probably down about 30%. So we're wondering, are these patients not coming at all? So it is a lingering concern for us, and I wish to encourage everyone to spread the message in the community that they should not hesitate to seek medical attention as you normally would. We have very, very good protocols to protect and keep everyone safe from COVID, even if you're seeking medical attention at the hospital.
Just absolutely critical message that I want to reinforce, that we're here to help you if you're sick, and you should not hesitate to come in. Certainly, when people have emergencies, they need to come into the hospital, they'll be safe. So Chris, tell us how things are looking in the OR. How have things changed since COVID? Have they changed the type of patients you're seeing? Are they sicker? Are there less of them? What from your perspective, what have you seen?
So we do see patients who tend to be a little bit sicker or presenting with some of the complications of heart attacks. So once somebody has a heart attack, there's the initial phase where they they have that acute insult, but then over the course of the next couple of days, there's complications that can happen that cause valves to leak, or that can actually cause the wall of the heart to develop a hole. And so we've seen a couple of patients that present with those complications, which are very rare. And you expect that it's because people are waiting out their symptoms and trying to see if they're going to improve, and they're just not presenting because of whatever the reason might be, whether that's because of fear of contracting COVID. But again, it reiterates the importance of having your symptoms assessed. I mean, the OR protocols have changed to make sure that the people operating and the patients are safe, to make sure that and not only safe from contracting COVID, but safe from having the best outcome that they can have. Because if we operate on patients who have COVID, other than in an absolute emergent situation, then that can affect their long-term outcomes. So there's a lot of care that's being taken to make sure that we can offer people a safe surgery and a safe recovery.
So, key message that heart disease is considered time sensitive, meaning that if we get to patients early, we have a lot of treatments, medications, lifestyle changes, some of the complicated surgeries and interventions you've heard that can really make a big difference. But we need to get to people early. So it's a really critical message. I'm going to ask a few more questions that have been given about COVID. So a question that I'll direct to Dr. Roifman to start with. So are patients who have heart disease or peripheral artery disease, are they more susceptible to getting a worse type of COVID? Are they more susceptible to getting more sick? What do we know about that?
So that's a very good question. There are a number of smaller studies that have looked at this, and they concluded that if you have a prior history of cardiovascular disease, a prior heart attack, prior heart failure, things of that nature, you are more likely to develop worse outcomes with COVID-19. Not more likely to actually catch it, but if you do catch it, more likely to have worse outcomes. In that way, it's not significantly different than people that have chronic kidney disease, people that have other diseases that are chronic. And it also, although it may be to a different extent, it's not different than other respiratory viruses. So we know that influenza, for example, greatly increases your risk of heart attack, and also if you have underlying heart disease, it increases your risk of having severe influenza. But obviously with COVID, the situation is exacerbated.
Okay. Thanks, Dan. So I've got a few questions about vaccines. And as everybody in the audience knows, the COVID vaccine, to some degree, represents really a bit of a miracle of science. To go from conception to actually mass rollout within a year is really an amazing achievement. And it's one of the kind of lights at the end of this pandemic tunnel. So we have a few questions about vaccines and the appropriateness in patients with heart disease. And I'll really open it up to anybody who wants to jump in. So the first is regarding vaccines and their safety in patients with heart disease. Is it safe for a patient with heart disease who's on medications for heart disease, such as beta blockers? Is it safe for them to get the vaccine? Maybe I'll ask Dr. Madden this one, and then Dr. Roifman can comment also.
Yeah, I have had the privilege of volunteering in the vaccination clinic at Sunnybrook over the month of January and as recent as yesterday, actually. Yes, I would think it's very safe for patients to get the vaccine. You will at the time of vaccination be asked what medications you're taking if you're on blood thinners, more so that we can anticipate any complication or any potential bruising or anything that we might cause by giving you the vaccine. But yeah, it's completely safe for patients on cardiac medications to get the vaccine. I'm not aware of any flags.
Roifman, do you want to add anything there on the vaccine and heart disease?
I agree 100%. It's very safe. I actually think there's probably going to be very, very few people that shouldn't get this vaccine. As we're doing more and more studies, they're starting to look at kids. I'm sure the kids will be approved for it. Pregnant women initially weren't included in the clinical trials, but now there's growing consensus that it's very important for pregnant women to also be vaccinated. And so I really think there's going to be very, very, very few people at the end of the day that should not have this vaccine.
So we have a few related questions, and this one's going to be directed to Dr. Trella, about patients who are waiting for heart surgery or who've had a recent procedure or about to have a procedure such as a pacemaker. If they get the call up for a vaccine, should they get it while they're waiting? Is there any concern there?
Yeah, I think I kind of agree with Dr. Madan and Dr. Roifman. I mean, it's important for this group of patients because not only, as Dr. Roifman alluded to, do they have the potential of having a more complicated course, but they have less reserve in order to help them recover, and so maximizing their opportunity for recovery by reducing the potential risk of contracting COVID or the symptoms that you might develop, I think would help definitely.
Perfect. So kind of consensus from our speakers, and certainly, I would also advocate strongly that the benefit of the vaccine at a population level really depends on people getting it. And if ever there was a time to advocate of its importance of helping us get out of this pandemic and prevent subsequent waves, it is a safe vaccine, as far as we know, for patients with heart disease who are at risk for potentially being sicker when they get COVID. It's particularly important. So certainly, as a group, we're all advocating for it. Now we have a few questions about SCAD, so I'm going to direct these to Dr. Madden. However, if our other two speakers want to jump in there, please feel free to add. So one of the questions really relates to the fact that you mentioned that heart disease is under-recognized in women in general. So how far have we come from having a vetting program, knowing that we don't recognize it as well in women, for women who do present to the emergency room? How have we got better at having protocols for vetting so that things like SCAD can be identified, that we're not kind of continuing on this trend of not recognizing and missing it in heart disease in women? Your comment on that?
So, good question. I think it's definitely a lot better than it was 10 years ago or 15 years ago, where women had a lot of trouble getting themselves heard. And even as recently as 5 years ago, some of my SCAD patients tell me it took 3 trips to the emergency room before somebody actually did a blood test or an ECG on them and didn't dismiss them with anxiety. So that's very sobering. But even in the last 2-3 years, certainly maybe because of my interest in SCAD, but it's even like patients coming to our emergency room when residents are admitting young women with heart attacks, it's one of the leading diagnoses now that is in the possibilities that it could be when a young woman under the age of 50, for example, comes in to hospital with a heart attack. So I am reassured that our trainees and our future doctors may well do a better job than we did looking for this condition. So I think like forums like this that increase public awareness are really important. And also a lot's been written about SCAD in the last 5-6 years. So there is increasing recognition of this condition. So we're slowly doing better. And I am encouraged by that. I do tell my patients to advocate so that if they've had SCAD and they have a big chest pain and need to go back to the emergency room, the first thing they say is, I've had a SCAD-related heart attack. It's okay if you don't know what that is. You can Google it like everybody else and have a look at what it is. And please keep me for a blood test and an ECG and get a cardiologist to see me. And that has worked very effectively for many of my patients.
It's a great message there that not only is public awareness important, but often, almost always, a patient knows their disease the best. And part of that is educating physicians and other healthcare providers. and it sounds like there is a culture change within the community of physicians of greater awareness of this. So there have been a few questions about how good is an angiogram of being able to truly tell the difference. So in a couple of questions of healthy women with no previous history who then been diagnosed with a heart attack, how sure can they be that during the angiogram that the correct diagnosis was made? Did they in fact have traditional heart disease or SCAD? How good is the angiogram? Your comments there, Dr. Madden.
Yeah, so the angiogram is pretty good. And I think as interventional cardiologists, I think we're getting better at recognizing the patterns. But it's not perfect. And I still have a number of patients referred to me each year where I look at the angiogram and I say, that's SCAD, or that's not SCAD, or actually you called that SCAD, but it was actually over here and not here. You know, so it was very interesting variation, but for most cases, it's very good. And for most cases, the diagnosis is getting made correctly. And sometimes, you know, there are certain types of SCAD. I showed 3 different patterns, and some of them tend to mimic coronary artery disease, the traditional type. And that's where doing advanced imaging can be helpful if you're not sure. And I think more people will pull out advanced imaging, such as intravascular ultrasound or OCT, to have another look if they're not sure.
So we have a few questions. We're going to switch gears now from the coronaries to the aorta. And I'm going to direct these to Dr. Torella to start. A couple have to do with aortic dissection. And perhaps the first one is, you described this condition that's a great masquerader, and that symptoms can masquerade as other things. Can it be prevented? Can people who have a family history of dissection or concern about it, are there any things to be done to try to prevent it?
I think that's an excellent question, and it shows initiative on people to try and optimize their health, and it again looks at those risk factors. So we talked about age, we talked about males having a higher incidence of aneurysms. We talked about high blood pressure, high cholesterol, and of course the genetic component. And in that list, we have what are modifiable risk factors and risk factors that we can't modify. And so those would be the genetics, that would be your age. But by maintaining a healthy diet, exercise, by controlling your blood sugar if you're diabetic, by not smoking, if you're prescribed high blood pressure or hypertensive medications or medications to treat cholesterol, then to make sure that you're compliant and that you're taking those medications. And those are really the best tools that we have in order to reduce the risk of having an aortic dissection. And the other thing is that if you do know that you have a family history of it, then to ask questions and to not be afraid of asking questions, because it doesn't hurt to ask and have yourself checked, or to have your risk assessed, so that you A, have peace of mind, but B, we can detect aneurysms early before we get to the point of having a dissection. So I think modifying those risk factors and asking questions and being an advocate for your health are important.
Perfect. So the second question related to aortic dissections is whether that can happen as a result of open heart surgery in general, as a complication of that. And if so, how frequent is it? And importantly, if it happens, can it be repaired?
And so that's another great question, especially with the number of people that are having heart surgery. And the answer is yes, it can happen, but it's rare. And so a lot of times when we do open heart surgery, we have to put people on a heart-lung machine, which is a machine that acts like our heart and lungs during the surgery. And that way we can stop the heart and fix the part that we need to fix and then start it again. And so in order to put someone on that machine, we have to put a series of tubes in. One of them takes blood out of your heart and it brings it to the machine, and the other tube puts blood back into the body. And so when we're inserting those tubes, then there is a risk of having a aortic dissection, although it's exceedingly rare, probably in the realm of 1 in 1,000. And so that being said, if it does happen in the operating room, you're more or less in the best place you can possibly be to have it fixed. But in terms of it happening after surgery, again, it is possible. Again, it is rare, and it can happen usually at that site where we put that tube in. But in general, once a few months have gone by, that risk is almost zero again, unless you have some predisposing condition that can cause you to develop a dissection to begin with.
So this one again is for Chris, and it's on the theme of complications after open heart surgery. So how frequent are infections, and what's done to reduce that likelihood?
So a great question, and there's a number of in terms of reducing the likelihood, there's a number of things that we do in the OR and in pre-op in order to help reduce that. So one of them is to use antibiotics that we give to each patient before we make an incision in their skin. We before surgery ask people to wash with a special chemical called chlorhexidine, which can remove some of the bacteria, and also to just clean those surfaces. And then after surgery, we continue antibiotics for a few doses in order to allow some time for healing. There's also a number of adjuncts that we use in the OR that are also related to antibiotics, meticulous surgical technique, and the other thing would be to control blood sugars in and around the time of surgery. And this again goes back to those modifiable risk factors, because I mean, diabetes is not only a risk for heart disease and cardiovascular disease, but also for wound infections. Some people who are diabetic don't necessarily check their sugars, and it's important to make sure that you have good glycemic control. And we actually try in the ICU after surgery to control it for you, very tightly regulated in order to reduce the risk of wound infection. And should you be unfortunate enough that a wound infection does occur, then it is treatable. Wound infections in the skin occur in roughly around 7% of patients, and that can be at any of the incisions. So when we do bypass surgery, we have an incision in the leg, sometimes in the arm, one in the chest. And so some areas, of course, heal better than others, just because they have more blood flow to those areas. But any of those are at risk. And then there's the risk that those infections can go even deeper and start to get into the bone, although that's quite a bit more uncommon and in the realm of around 1% or less.
Okay, thanks very much. So now we're going to switch gears a bit. And in our remaining time, we've got quite a few questions that aren't necessarily related to the talks that the three of you gave, but it's not often that they have three heart specialists available for questions. So these are going to be more general ones. And the first few, I must say, I'm so glad to see, because they really center on prevention. So this one I'm going to ask first to Dr. Madden, and then if Dr. Roifman can comment. And these are probably kind of cardiology 101 questions that you get from all of your patients. So how do we become aware of heart problems in our daily lives before they become serious? Like, what should we be doing in our day-to-day?
Okay. So I'm a little less stressed. I was wondering what was coming, but sure. So basically, it's we're looking for symptoms of heart disease. So chest pain with severe emotional stress, chest pain on exertion. Those are the kinds of symptoms that we're worried about. Chest pain that comes with exertion and goes away with rest. This is what we would be worried about, and whether it is angina. Putting that together with any presence of risk factors, such as what many of the other speakers have mentioned, so high blood pressure, diabetes, cholesterol, smoking, family history, particularly of premature heart disease and before the age of 55, would be things to be looking for. I would think that you should start in your 30s and 40s, start thinking about what is your personal risk, having a conversation with your family doctor, being screened at an annual health review for your blood pressure, for the presence of diabetes or high cholesterol, and you know, keeping a healthy weight, keeping smoke-free if that's possible for you, or at least reducing the amount of cigarettes you consume if quitting altogether has been very difficult. So these are the kinds of things that we're looking for and that get our attention and generate requests for advice from family physicians. Maybe the others have something to add too.
Dr. Roythman?
Not much to add. I think Dr. Madden said it perfectly. It's the symptoms, and then remember that a lot of this is in our hands, right? It's important to remember that it's not predestined. Even people with severe family histories can change the trajectory by focusing on the stuff that they could do, the modifiable risk factors, which are the same modifiable risk factors that Dr. Rolla talked about earlier.
Perfect. And in fact, that was one of the questions: is heart disease always hereditary? And if it's prevalent in generations of family, are healthier habits, do they still make a difference? And I think both of you have reinforced that, yes, it is. And certainly speaking as a cardiologist, I'm most happy about the patient who never has to see us because they made all of the changes in their lifestyle, worked with their family physician, they got screened, and they never got to the point where four of us had to do any of the fancy things that we do in our day-to-day. That's a good thing, and that's really what we would encourage. We have a few questions about arrhythmias. So none of the doctors on this line are arrhythmia specialists, but as practitioners in heart disease, all of us see it. So a question is, what is an arrhythmia of the heart? Can it be life-threatening? Maybe I'll ask Dr. Roythman to take that one.
Sure. So arrhythmias simply mean an irregular rhythm of the heart. So our heart usually has a normal rhythm that's very regular, and it beats, and you could actually check it yourself if you just take your pulse, and normal pulses would be very regular and beat at less than about 100 beats per minute, or even less than that when you're at rest. And obviously when you exercise, it goes higher. Arrhythmias is just anything that deviates from that. So most arrhythmias are completely harmless. Little skip beats, little, what we call sinus tachycardia, which your heart rate can elevate during certain times, maybe a bit more than it should. But there are certain rhythms that people need to look out for. One of them is atrial fibrillation, which a lot of people know about. A lot of people that are famous and athletes can get it as well. It's the most common cause of stroke in North America, and I believe in the world. And that's an irregular heart rate, which can actually be picked up by some of the smartwatches these days. So I think that it's important to be cognizant of that. And if you do have an irregular heartbeat, it's important to seek advice and attention. But again, even with atrial fibrillation, there are things that we can do to help reduce the risk of bad outcomes happening. It's important to get detected.
Perfect. Thank you. So we now have a question about surgery, and the next couple are. So there's a question that I'm going to direct to Dr. Frola as the cardiac surgeon, and it's, is there other alternatives to fixing the heart valves other than open heart surgery?
Well, that's a great question, and something that we at Sunnybrook do a lot of research in and have huge programs in repairing valves through open heart surgery, but also through through different devices. And so Dr. Wijasundara and I are both part of our TAVI program at Sunnybrook, which is a transcatheter aortic valve replacement. So that's a technique that, again, with a catheter about the size of a pen, we load a valve onto it that is kind of spring loaded or can be opened up with a balloon, and we put that through the groin or a number of other access points, and we can implant a new aortic valve using that catheter-based system. The same exists for small devices that are kind of like little clips in order to treat leaking of the mitral valve, which is one of the valves on the left side of the heart, and also to replace those valves. So there's a number of ways that we can do valve surgery without needing to open the heart. But the thing to keep in mind is that those devices or that everybody isn't built exactly the same. And so sometimes based on the way that somebody's anatomy is, or based on the type of problem that they have, we can't necessarily use those for each person. And so although they're available, and although we're doing a lot of research and innovation in order to make those more available or more generalizable, they're still not for everybody.
Perfect, thanks, Chris. And that really comes to the second part of that, which was, why don't you do it minimally invasive for everybody? And I think you answered that. So the final question is also a little bit different than what the topics that you asked, but that you spoke on, but it has to do with diet. So you've commented on lifestyle changes to reduce cholesterol already. One of the questions is that most of the heart diets that they've noted are intended to reduce cholesterol. And if a patient's cholesterol levels are fine, but their issue is heart failure and they're living with heart failure, is there diet or lifestyle changes that would help them? And so maybe we'll start with heart failure. Sounds like an awfully ominous term. So maybe I'll ask Dr. Madden if she could define what heart failure is for the audience, and then comment on what type of lifestyle changes she advises for her patients who live with heart failure. And then I'll ask Dr. Roithman also for his comments on it.
Without being a heart failure expert, I think all cardiologists see some degree of heart failure in their practices, and heart failure is often due to reduction in heart function, which can also lead to congestion or collection of fluid on the lungs, difficulty breathing. So basically, though, in more general terms, heart failure refers to inability of the heart to pump blood in a manner that provides all the vital organs with enough oxygen. And that can occur actually in the setting of reduced heart function, and sometimes can also occur in the setting of a stiff heart and preserved heart function. So I guess that would probably be the most simple definition. Did you want me to go further in terms of?
Yeah, the type of lifestyle changes that you recommend for patients who are living with
heart failure. Sure. So I recommend to my patients a couple of things. First, three things actually, simple things. First of all, following a low sodium diet, because that's associated with fluid retention. And then also fluid restriction. To at least, no more than 8 cups of liquid a day. Certainly we think that less than 6 cups of total liquid consumed a day is probably very difficult for most patients to do. And so that's so 1.5 to 2 liters a day. And I also ask patients to weigh themselves daily. And sometimes we have patients modify the dose of diuretic therapy that they're on, which many of these patients are taking, based on their daily weights. And that often helps keep them out of hospital and in their homes.
Dan, do you want to add anything to that?
I thought that was excellent. The only thing I would add is the statin piece. So I think that was embedded in maybe part of that question. It depends on, I guess, the reason for the heart failure, right? So The most common reason for heart failure is actually blockages of the arteries. Remember the cholesterol buildups that Dr. Madden showed a nice example of, a nice cartoon of. And if that's the case, then diet and exercise are super important, but may not be enough to treat the underlying cause. And so you may need to stay on your statin pill.
That's a good point. Yeah.
So that's actually all the questions. And, I would like to thank the audience for sending the questions in, and thank the speakers who really, I have really illustrated what the Iliac program is all about, that in addition to kind of cutting edge imaging, new devices, treating patients with really cutting edge research and kind of new emerging diseases such as SCAD. They've also shown how much work we do on prevention and bread and butter cardiology, which is so critically important. I just have a few more points before we wrap up the evening. To the audience, if you could please take a moment to fill out the electronic evaluation form on our website. This will help us plan future talks and topics that will be of interest to you. And so with that, I'd like to thank our speakers once again for really an incredibly educational evening. And a big thank you to all of you for joining us for this discussion. And please make sure to check out our upcoming topics. And there are lots of details on our webpage at www.sunnybrook.ca. So with that, thank you all and have a great evening.